hospital-based dentistry for infants and children, and particularly for children with special healthcare needs. Prof. Umar today will be taking us through the topic of pulp therapy in primary teeth. Prof. Umar, we are delightful to have you here. The mic is all yours now.
Hi, uh, thank you. Um, can you guys hear me?
Yes.
All right. Selamat pagi semua. Sorry, see, I made a mistake. Selamat semua. Okay, I made a mistake again. Selamat tengah hari semua. Warm greetings from Malacca Manipal Medical College. Before I start my presentation today, I would like to congratulate the Executive Committee of MAPD for organizing this webinar series. I would say that it is a fantastic idea to organize this lunch series. I would also like to take this opportunity to thank Dr. Joanna, Dr. Anna, as well as Dr. Faisal for giving me this opportunity to share my experiences, as well as the current guidelines which are available with regards to treatment of primary teeth with which need pulp therapy. So let's start. So most of us who have been seeing children with for dental treatment, we come across dental caries. We see that we see children who have teeth with multiple dental caries. We see children who have deep dental caries, teeth with having deep dental caries. We see also children who have pulp exposures due to various reasons. We also have come across children where the infection has been chronic, and finally there is fenestration of the roots of the primary teeth. And further, not but last the least, we also see children who have swelling of the face. Now, in all these scenarios which I have shared with you so far, in some of the situations, the treatment plan is pretty straightforward. The management is pretty straightforward. However, sometimes we come across situations where the treatment is not so very clear. We always are in a dilemma. What would be a better approach? So therefore, my dear colleagues, today I would be talking to you about why do we need to do pulp therapy in primary teeth? What are the objectives? How do we make a decision? What are the different types? And along the way, I will share certain clinical tips which will help us in the long run. Now, why do we need pulp therapy in primary teeth? The simple reason is if there is a premature loss of primary teeth, this would lead to malocclusion. It will also lead to aesthetic, phonetic, and functional problems, which could be transient or permanent. Now, as you can see in the picture here, you can see that the second primary molars in the upper arch as well as the lower arch have been extracted prematurely, and there is a loss of space. So this is going to be a future malocclusion. So pulp therapy probably would have helped in this situation. Now, the other aspect is, which we see very often in this part of the world, is that we see a lot of children with retained primary teeth and with no successor. Now, in these teeth, sometimes when they have decay, as you can see here, it's imperative on our part to save these teeth and hold on to these teeth for as long as possible till the child is ready to get a final restoration in the form of an implant when his growth is complete. So in this situation, pulp therapy again will help us in retaining the tooth for a long time. And finally, there's another situation. Many times if we have a crowded arch, in such situation, if we extract a primary tooth with having deep caries, then in an already crowded arch, we are going to create more crowding. So holding on to the primary tooth till a longer time definitely does help in preventing malocclusion in the future. So when we see children with multiple decayed teeth or children who are coming to us with abscess teeth, by performing pulp therapy, it helps us in maintaining the integrity and health of the teeth as well as the supporting tissues, and it helps us in ensuring that the functionality of the tooth is not compromised and it is still functioning as a single unit. Now, having said that, Before we embark on performing the pulp therapy, we need to know the status of the pulp. We need to know whether the pulp is normal. We need to diagnose if the pulp is normal and therefore is it symptom free. Uh, and then the other thing is we need to diagnose if the pulp is is showing any signs of reversible pulpitis. Therefore, in other words, it is capable of healing. And then it is also, we need to diagnose if the pulp is having any signs of irreversible pulpitis, because then it will tell me whether it is, if the pulp is vital. It tells me that the pulp is vital, it is inflamed, but it is incapable of healing. And finally, I also need to look for signs to show that the pulp is necrotic. Now, these are very important steps for me, because based on these signs, I will be able to decide on the management of the tooth which is involved. Now, in order to make diagnosis, in primary teeth, there are certain diagnostic challenges. In order to make diagnosis, first and foremost thing is to take a history. Unfortunately, in children, it is not very easy to extract the reliable history from the child. Most of the time, it's the parent who tells us. Now, in the absence of a history or a reliable history, I depend on certain tools like which will tell me the status of the pulp. Like, for example, I need to know if I can use electric pulp testing or thermal pulp testing, which we usually routinely use in permanent teeth. However, these are unreliable in children. And in the absence of these two, the only thing which can reliably possibly tell me is a histopathologic picture. However, research has shown that the clinical symptoms and histological pictures sometimes don't go hand in hand. So therefore, there are certain advanced tools like pulpoximeter, or there are certain advanced tools like pulse, laser Doppler flowmetry and all this. But unfortunately, sometimes we cannot use these in children. But so this means that we have a challenge. However, it can be overcome. So in order to decide about pulp therapy, it is very essential that we follow certain steps because these are the key in the management. It starts with the history, and in the history, the first and foremost important thing, which is very important, is the age of the child. Because the age of the child, it tells me whether I need to save the tooth or extract the tooth. For example, if we have a child who's 5 years old and he has come to us with a severe pain in relation to 7.5 and possibly a swelling, I will take every step to save this tooth, because this, if I extract it, I'm going to create a future malocclusion if I'm not able to give a space maintainer. But if a child who is 10 years of age and he comes with a severely decayed with the same situation, pain in 7.5, I can safely extract. I don't have to retain the tooth because it's very close to exfoliation. Now, the other aspect is taking a history of the pain. While the child may not be able to give a true picture, but the parents can give us a fairly good history in terms of when, where, and how, because this helps me in ascertaining if the child is having reversible pulpitis or irreversible pulpitis. And then a very important aspect of doing pulp therapy is knowing the medical history. Now, we come across a lot of children who are medically compromised. They have certain situations where we need to do pulp therapy. For example, in hemophilia, we need to hold on to the tooth. Whereas a child who's immunocompromised, an infected tooth is a focus of infection. And if we do not, sometimes we may not opt to do a pulp therapy because it's a focus of infection. And if there is a flare-up at a later time, it can be life-threatening for the child. So history is an important component. Once we have done the history, the other aspect is the examination. Examination is the most important thing. Many times children come to us with a swelling. They may have pain, they may not have pain. They may have extraoral swelling, they may have an intraoral swelling, or they may now have neither. They may just have draining sinuses. But all of these tell me the status of the pulp, that pulp is irreversibly damaged, and it's irreversibly damaged. And the next thing is that I know what is the treatment I need to do, number one. And the only thing I need to do is, can I do this treatment or not? So a clinical tip would be for us, which is like we should always check the gingiva, the soft tissue in the anterior region, lift the lip, or in the buccal side, if you come across a tooth which is grossly decayed, it's a good practice to check the gingiva, because that gives us the indication that the tooth, what is the kind of treatment the child will need. Apart from that, the other thing is the thorough examination of the tooth. Now, in this picture, you can see that both first and second primary molars, they have large caries, but you can also see that there is a lot of food debris. So when we examine, we need to check this thoroughly, because it tells me the depth of the caries, number one. It also tells me if there is any pulp exposure, and further I need to ascertain whether it is carious pulp exposure or mechanical pulp exposure. Carious pulp exposure is the one where the tooth is surrounded by decay, and the status, the pulp here, the prognosis of the pulp is poor, because it could be grossly inflamed. Whereas mechanical pulp exposure is the one where it is a clean exposure, which is surrounded by healthy dentine, and the prognosis for the pulp is very good. So I need to ascertain, because again, my management will vary, it will differ. And of course, I should always look out for polyps, and then I have to decide, I have to ascertain whether it is a pulp polyp or a gingival polyp, because again, the management differs. And many a times we may not be able to ascertain diagnose the status of the pulp by history or with the help of examination. In such cases, we do what is called as operative diagnosis. What exactly is that? I'll come to that later. Now, once I have made once I've done the examination, the other aspect also is to look for mobility. We need to decide whether it is physiologic or pathologic, because in children, many times the teeth will be mobile on their own because of they are close to exfoliation. And then we have to know whether it is pathologic. And whenever in doubt, always compare with the contralateral side. And we look for fluctuation and percussion. If any of these is present, we know that the pulp is involved, and I know what treatment I have to do. And the only thing I need to know is whether I can do it or not. So the only tool which will help me to decide this is with the help of a radiograph. Now, a radiograph is not telling me it's only, by now I have a fair idea what I'm going to do, what kind of pulp therapy I'm going to do with the help of history and examination. Now, with the help of a radiograph, I'm only confirming whether I can do what I need to do, what I plan to do. Because usually I personally prefer to take an OPG for a child who comes with multiple caries, because in one film, I get to see everything and I don't need to take series of radiographs, which is uncomfortable for the child. So, however, if the access to OPG is not there, a good quality IOPA will do the job. Why? Because when I take an IOPA, it tells me whether there are any previous pulpotomies and pulpectomies. It will show me the depth of caries. It can also show me failed pulpotomies and pulpectomies. It can also show me if there is any resorptions, root resorptions, or any internal resorptions. So radiograph is an important tool. So in order to summarize, before we start the treatment, apart from the age, which is an important criteria, the second most important thing is the medical history. And then is an important component is we need to know the value of the tooth which is involved and its correlation with the development. What do I mean? If you see in this picture, the first primary molar is grossly decayed, and in this child, the first permanent molar has not erupted yet. So therefore, everything, I need to take steps to hold on to this tooth so that there is no space loss. But before I do that, I also need to know if the tooth is restorable. So if the tooth is not restorable, in that case, I have to look at alternatives. So the point is we need to hold on to the onto the teeth, primary molars especially, before the eruption of the first permanent molars, because loss of these will lead to future malocclusion, as I stated before. Now that we have decided we need to do pulp therapy, now what are the types? Now, depending on the approach you want to use, you can say I'm going to be conservative, or I can decide to be radical, or I can say, depending on the status of the pulp, I may say I want to do vital pulp therapy or non-vital pulp therapy. So in vital therapy, indirect pulp capping, direct pulp capping, and pulpotomy, they come under the umbrella of vital pulp therapy, whereas non-vital pulp therapy, pulpectomy comes under non-vital pulp therapy. Now let's look at them one by one. Now, in this case, if you see the primary, both the primary first and second molars, they have deep dentinal caries, and the patient gives a history of provoked pain, and it has pain on and off, but clinically there are no signs of any sinus, there is no swelling. So this is essentially, it's deep caries, but it is it's asymptomatic in the sense like there are no signs and symptoms of sinus. So indirect pulp therapy is done in a tooth with deep carious lesion, which is very close to the pulp, but there are no signs or symptoms of pulp degeneration. Now, what is the objective of doing this? Now, because it's asymptomatic, there are no signs of degeneration, so I need to ensure that the pulp remains vital here. So by doing indirect pulp therapy, we are arresting the carious process, we are promoting secondary dentine formation, we are stimulating the formation of tertiary dentine and remineralizing the remaining carious dentine. So what happens is all these put together will help in maintaining the vitality of the pulp. Now, what is the rationale? Once we do the indirect pulp therapy, that means we are leaving a layer of carious dentine living there. So the rationale is that very few viable bacteria are left there and in the deeper dentine layers, and in the presence of a properly sealed cavity, these bacteria get inactivated and the vitality of the pulp is retained. Now, the key word, the caveat here is the cavity has to be sealed properly. There should not be any leakage. So how do we do it? So if you see in this picture, you can see that there is deep dental caries, and because of the deep dental caries, there is slight inflammation of the pulp. And then we remove all the soft caries which is there on the DEJ as well as all the lateral walls. When it comes to the floor, or in case it's an axial wall, we leave a thin layer of decay over there, because we know that if we remove it, it is going to cause pulp exposure. And once we are sure and we restore it, we place a medicament like calcium hydroxide. We can use a medicament like calcium hydroxide, or we can simply restore with reinforced ZOE or a glass ionomer, or you can also use mineral trioxide aggregate, and you need to seal it. The key here again is the margins of the cavity should be thoroughly sealed. Otherwise, this procedure will fail. So typically we use spoon excavator, or we use slow speed handpiece or with a round burr, but there are certain other methods of removing soft caries. You can also use chemomechanical approach. Caryzole is a material which has been there, which comprises of amino acids, 3 amino acids in a mild sodium hypochlorite solution, and it comes with special instruments. So the advantage of this is that it does not harm the sound dentine. And similarly, Pepacare, which is made up of papain, this also will again remove only the soft caries and will not harm the sound dentine. So these are pretty useful in terms of they are not threatening to the child. But the only disadvantage, I have used Caryzole, I feel that it takes way longer to use, because you have to place the material and you have to wait for it to work before you will be able to remove the soft caries. And sometimes in a child who's a little anxious, it may not be very feasible for us to use. So for every procedure, I've prepared a checklist based on the history and examination. So indirect pulp therapy is done only when there is provoked pain, and when there is deep caries, and when the radiograph shows that the remaining dentine thickness is less than 0.5 millimeters. That's when we do indirect pulp therapy. Now, earlier the concept was, we all read with the concept that once you do indirect pulp therapy, you need to re-enter into the cavity after 6 to 8 weeks and see that the remaining dentine which is there, soft caries is there, and it is hardened, you remove it and all that. But now the current concept is that you don't need to do it if again the caveat, if the restoration is completely sealed, well sealed, and there is no sign of any indication of any leakage, micro leakage, and there is no bacterial contamination. So so long as your restoration is intact, you don't have to re-enter. If the patient is asymptomatic, just leave it. You don't need to do anything further. What is the success rate? In the recent times, indirect pulp therapy has seen a resurgence in management of deep dental caries in primary teeth, and it has been seen that the success rate is more than 90% in primary teeth, and in long term, it is actually way better than pulpotomy. But again, as I said, we should embark on indirect pulp capping only if our assessment shows that we can give a final restoration which is leakage resistant. If it is not possible, then indirect pulp therapy is not going to work. The patient is going to come back with a swelling. So a clinical tip for doing indirect pulp therapy, as I think I've repeated myself 4 times now, most important is we need to prevent micro leakage. Your final restoration has to be perfect. There should not be any leakage, number 1. Then the dilemma comes, how much of caries should I leave? How much should I remove? So the key here is, typically they say you keep removing till you feel that if I remove any more, I'm going to cause pulp exposure. But that comes only with experience. But a general guideline is anything which is soft and mushy, remove it. Anything which is hard, just cap it indirectly. And the other tip is use a large round burr, which is number 6 or number 8 on a slow speed handpiece, because you have a better control. It does not aggressively remove the caries. Many of us, including me, I have used a spoon excavator, sharp spoon excavator, but over the years, I have a better control, but sometimes you can be aggressive and you may cause pulp exposure. So using a large round burr will definitely will ensure that you don't cause pulp exposure. Now moving on to direct pulp capping. Direct pulp capping is very restricted, and it has to be done only in certain situations where there is a pinpoint mechanical exposure of the pulp during cavity prep or trauma. Many times we had a situation where the student was preparing a cavity and the child decided to move, and because it was an unexpected move, the bird dipped in the cavity and there was an exposure, but it was a pinpoint. So the point is, it is a clean exposure. It is not an infected exposure. So in such a situation, you can use direct pulp capping, where you place a biocompatible material like calcium hydroxide or MTA, and then again, you have to restore with a good restoration without any micro leakage. So the checklist here is that in the direct pulp capping is done only when there is either a mechanical exposure of the pulp or exposure due to a small pinpoint exposure due to trauma. Coming to the success rate, now in primary teeth, I am reiterating, in primary teeth, direct pulp capping is the most controversial treatment so far. And the success rate, it has not been found to be highly successful in deciduous teeth. So I would do direct pulp capping with extreme caution. I limit myself to doing direct pulp capping only in cases where there has been a trauma or where there has been an exposure during cavity prep. Otherwise, I don't do direct pulp capping. Now moving on to pulpotomy. Now pulpotomy is one procedure which has been researched the most amongst all pulp therapy procedures. And as the definition goes, it's basically amputation of the coronal pulp followed by placement of a medicament to preserve the vitality of the radicular pulp. So basically it goes, what is the rationale? It is based on the premise that the symptoms which the patient is giving, which is a dull pain, which keeps coming and going, but it lasts a little longer. The only thing it is telling me is that there are signs of irreversible pulpitis which are showing this, it has started, but the inflammation is restricted only to the coronal pulp, but the radicular pulp is healthy and it is capable of healing. This is the premise on which it is based. There is no way of knowing it because there are no tests which can tell me unless I use advanced methods, as I mentioned before. So once I amputate the coronal pulp, as you can see here, once it is, so the medicament which I place, it can either make the radicular pulp inert, it can preserve it without inflammation, or it can help in regeneration. So depending on the treatment objective. That means depending on the outcome, whether it is inert or regenerative or it is preservation, pulpotomy can be called as devitalization depending on the agent used. You can use formocrosol, glutaraldehyde, electrosurgery, or laser. It could be also called as preservation type, where there is minimal devitalization and there is minimal inflammation, and it only preserves the remaining radicular pulp. And here we use ferric sulfate or sodium hypochlorite. And of course, there is the regenerative, where there is inductive or reparative formation, or there is a secondary dentin formation. There is a calcific bridge, formation. So here we can use calcium hydroxide or mineral trioxide aggregate, or we can use also calcium enriched matrix materials. So either we can be call pulpotomy based on the treatment objective or on the technique. Either I can say I'm doing a pharmacotherapeutic pulpotomy or non-pharmacotherapeutic. So pharmacotherapeutic is self-explanatory. We use all different kinds of materials, and there is a huge plethora of materials which are available, which have been tested for pulpotomy. And non-pharmacotherapeutic would be electrosurgery or laser. So now what material, an ideal material, pulpotomy material, should be bactericidal, it should be harmless, it should not interfere with the normal root resorption, and it should promote healing. Unfortunately, none of the materials satisfy all these requirements. So the research is still going on. So historically, calcium hydroxide was used as early as the early 19th century, and it has been used for various things and is the most commonly used material in dentistry. However, the use of calcium hydroxide as a pulpotomy material, especially in primary teeth, has been controversial because a lot of resorptions are seen, internal resorptions are seen with regard to calcium hydroxide. The second most common material which has been used for the longest time has been formocrosol, to the effect that it has been a gold standard. It was introduced by Swede in 1932, and it was called, he called it as the Buckley's formocrosol, which contains 19% formaldehyde and 35% cresol and 15% of glycerine, rest is water. And it was used for the longest time. And they said you use this for 5 minutes at the root stump and use it. However, later research showed that you don't need to use full strength. You can dilute to 1/5 concentration, and you don't have to apply for 5 minutes. You can apply for 1 minute. It gives the same effect. But when you use formocrosol, it causes complete fixation of the radicular pulp, whatever is left. And formocrosol has been found to be toxic, and there have been reports of it being carcinogenic. So a lot of flack has been given to formocrosol. But recent research has also shown that the quantity of formocrosol which is used may not cause the effects, the side effects which have been reported, but is minimal. But since people are wary of using it, there are still quest for more materials. So the other most popular material is mineral trioxide aggregate, MTA, which was introduced by Thorobinajad et al. In 1993. Initially, they came up with the gray MTA, which is essentially tricalcium silicate, and it has bismuth oxide. But the disadvantage, and other ingredients are there. But the disadvantage which was found was that the teeth turn gray. There is discoloration of the teeth. So then they came up with white MTA, and but a disadvantage which many people find is that it is expensive, and the way it is packaged, once you open the packet, you cannot use it again, and a lot of material is wasted. So recent reports have shown that Portland cement is one more thing which is being promoted, is being researched as a pulpotomy agent. And this is basically the side change in the composition, and that's about it. And then comes ferric sulfate, again a very commonly used material in dentistry, which is a common hemostatic agent. And this has been also studied a lot, and it is a good replacement for formocrosol. And sodium hypochlorite, since 2004 in University of Iowa, it has been used as a pulpotomy agent. Now, Sodium hypochlorite, we know, is the most commonly used irrigant for the root canal treatment, and it has been studied that it can be used for 5%. I am here only showing you 5 materials, but there are way many. There is biodentine, bone morphogenic protein, there's freeze-dried bone. People are studying, but a lot of long-term studies have to be there. The long-term studies have been there on formocrosol and MTA and ferric sulfate and calcium hydroxide. Now, if I see the checklist for pulpotomy, if there is history, there won't be history of spontaneous pain, but they might be provoked pain or dull throbbing pain, which will be lasting for a longer time, and the patient will not be awake at night. The caries will be deep, and when you take the radiograph, it will show that the pulp is exposed, and rest of the internal root length, everything will be normal. There won't be any other finding. Now, coming to the technique. Now, since pulpotomy is based on the Sorry, I believe my slides are not seen. Can I pause for a minute, please? Hello?
Sure, Prof. Sure, Prof.
Sure, Prof. Sure.
You can't see the slides? I'm sorry, I didn't realize.
Sorry, actually, we can see the slides for the participants. You just need to go to the panel and click on the presentation. It's pinned. You just pin the presentation because somebody accidentally presented and took over the space, but your presentation is still there. So
You can see?
request the participants to go to the panel and pin the presentation. You will be able to see it.
Hello?
Yeah, we can hear you, Prof. We can hear you, Prof. Another option, Prof. Because sometimes it got there's hang for the presentation. You can stop presentation and then represent again. Go to the current slide.
Okay, so should I do that? Are you able to see?
We can only see, but because we don't know whether it will be a smooth transition. If
Okay.
you can restart, yeah, you can just stop presenting and go represent again to that current slide.
Okay, I'll do that. No problem. Sorry about this.
It's okay, Prof.
No problem, bro. No problem.
Okay. Okay, now. Present now. Window. Present. Share. Is it visible now?
Yes, Prof. Yes.
Coming,
And
yeah.
some of the participants are asking if you can go back to the previous 2 slides because they can't really see the previous 2 slides, Prof.
Okay. Is this the one? Or
One more. Yes.
okay.
Thank you,
Is this
Prof. Thank you.
Sure, no problem. So, shall I start?
Yes, Prof.
Yes, Prof.
Okay, my colleague is helping me, and I'm not looking at my phone. No messages are coming. I don't want to look at my phone, so it is distracting. So I'm sorry if there is anything you interrupt me and say because I'm not looking at my phone at all.
That's okay.
Yeah. So, all right. So sorry for the brief interruption. Coming back to the materials, a material which we want to use for pulpotomy, it has to be bactericidal, it has to be harmless, it should not interfere with the normal root formation and not normal root resorption, sorry, and it should promote healing. And there are various materials. Calcium hydroxide has been the oldest, and it was used as far back as in the early 19th century. Unfortunately, calcium hydroxide as a pulpotomy material for primary teeth has not is quite controversial because a lot of resorptions, especially internal resorptions, have been observed with calcium hydroxide. So, of late, we do not use calcium hydroxide at all as a pulpotomy material for primary teeth. Now, the second most commonly used material so far has been formocrosol. It was introduced by Sweet in 1932, and he called the formocrosol as Buckley's formocrosol, which contains formaldehyde, 15%, 39% of cresol, 15% of glycerine, and water as a vehicle together. And At that time, they said you apply it on the root stump for 5 minutes, and it is fine. But then later research showed that you don't have to use full strength. You can dilute it to 1/5. That means you take 1 part of Buckley's formicrosol and you add 3 parts of glycerine and 1 part of, and you make a diluent with glycerine and water, and you add 4 parts of this diluent, and you can use it, and you don't have to apply for 5 minutes. 1 minute is more than enough. Unfortunately, with formicrosol, there were reports of toxicity and it being a carcinogen because it's a formaldehyde. So a lot of research has gone in, but some of the newer research has shown that the amount which we use for pulpotomy is very minimal. So it may not cause that much harm, but once a report comes, people are wary, which is fair enough. So there is quest for newer materials. So MTA was one of them, which was introduced by mineral trioxide aggregate, which was introduced by Torobenajad et al. In 1993. Which is basically tricalcium silicate with bismuth oxide and other ingredients. The only problem with it was causing discoloration of the crowns. So then they came up with the white one. But then with MTN, a lot of people have faced problems. Even we also encountered is that it comes in a sachet. So once you open, you cannot reuse it. It hardens. So now recently they're promoting what is called as the Portland cement. The composition is more or less the same. Only the bismuth oxide is replaced. So that is one more material. But this is the one which is the most favored material of late and has shown very good results as a pulpotomy material. Then the other very common material which we use in dentistry is ferric sulfate. It's a good hemostatic agent. This has also been studied as pulpotomy agent. And then there is sodium hypochlorite, which is quite recent in terms that since 2004 it has been reported to be used. It was first reported to be used from University of Iowa. And again, since sodium hypochlorite is so commonly available in dentistry, so this has been used very widely. Now, my checklist, again, on basis of history examination, the checklist shows that pulpotomy for the patient, there won't be history of spontaneous pain, but he may have provoked pain or he may complain of dull throbbing pain, which remains for a longer time, but he will not wake up at night with pain. Then when I examine the caries, there will be deep caries, and they will also be when I look at the radiograph, it will show me that the remaining, that the pulp is exposed. However, there won't be any focal radiolucency or periradicular radiolucency. So that's when I know that I can do pulpotomy. Now, how do I do it? Now, since pulpotomy is being is based on the premise that the radicular pulp is healthy, so we have to ensure that the procedure which we do is completely sterile and there is no contamination. So therefore, first you have to give the LA. You have to do this procedure under rubber dam, and then first is to remove all decayed dentine before we enter the pulp chamber. Now, once we enter the pulp chamber, there are 3 possibilities. Either, as you can see in this picture, you will have a bleeding point, or 2, once you dip into the pulp chamber, you may see pus, or you may see nothing. If you see pulp or pus, or if you see nothing, that means you cannot do pulpotomy anymore. You have to do pulpectomy. So this is operative diagnosis. That means I was thinking I can do pulpotomy, but unless I started the procedure, I thought I could do pulpotomy, but now the pulp is telling me a different story. I have to change my technique. So my pulpotomy will convert to either pulpectomy, or I may decide I don't want to do pulpectomy. I may end up extracting. So if you encounter pus or nothing or necrosed pulp, you just terminate pulpotomy and stop the procedure, and then either you decide I do pulpectomy or do the extraction. So once you come across the blood, you need to deroof and amputate the coronal pulp. Again, you can use a sharp spoon excavator, or you use a large round burr at slow speed. Remove all the residual tags. And the next important step is to achieve hemostasis. And this hemostasis is achieved only by using a damp cotton pellet No hemostatic agent to be used, only damp cotton pellet with gentle pressure. Why? Because we are again going with the premise that the radicular pulp is healthy, and there is no way of knowing, and only if I allow the pulp to stop bleeding on its own, I know it is healthy. So as you can see in this picture, the coronal pulp has been amputated, the bleeding has been completely arrested, there is no further bleeding. So now I know I can continue with my pulpotomy. However, if after removing the damp cotton pellet, I encounter bleeding again, the pulp starts bleeding again, terminate pulpotomy. You have to either do pulpectomy or you need to extract. So once I've achieved hemostasis, then I place my medicament of choice. Either I use formocrosol, I use MTA, I use biodentine, or whatever is available to me, and then cover it for the duration it is supposed to be used, and then I cover it with ZOE and I give a final restoration with stainless steel crown. So this is how it looks. This is the access made. You can see a bleeding point, completely de-roofed, all the coronal pulp removed, bleeding arrested. And here, in this case, here MTA is placed. And after this, we seal it with ZOE and we give a final restoration with a stainless steel crown. So coming to the success rate, it has been seen that when emergency pulpotomies were done, that means a patient has come and the patient is having dull pain, and which has been on and off. And when it was pulpotomy was done and it was followed up for 3 months, it was found that the success rate was low. This could be attributed to that probably there was some subclinical inflammation in the pulp, radicular pulp, which was there, which could not be diagnosed, and therefore the failure is there. But overall, for pulpotomy, formocrosol, as I said before, it has been a gold standard, though it has shown the success rate from 70% to 90%. However, since it is a gold standard, against it other materials have been tried, and MTA seems to be much more gives a better success rate compared to everything else. In case MTA is not available, ferric sulfate is a fairly good material which gives a success rate close to formocrosol. There might be some root resorption, but it can be managed. It is acceptable. But in the long run, it has been seen that long-term success of pulpotomy usually drops. Initially, it will be successful, but as you can see in this table, it drops over a period of time. So you can choose whatever material you have, you can choose, but case selection becomes very important. Now, while we do pulpotomy, there are certain side effects. The first and foremost is internal resorption. Internal resorption is one of the side effects, but again, certain authors, they think that if the resorption is initial and it is self-sealing, it is okay, but if it continues, you have to remove. So it can, that is something which has to be kept in mind. The teeth which undergo pulpotomy, they undergo early exfoliation, and it has also been reported that some of the teeth which have undergone pulpotomy can develop dentigerous cyst. Now, why the pulpotomy fails? The crucial thing while performing pulpotomy is the case selection. So if your case selection, if you are a little unsure, or if there is bleeding and you ignore after amputation, if there is continued bleeding and if it is not acknowledged and you continue, it is going to fail. And the most important thing for the success of pulpotomy is the final restoration. I cannot emphasize, I have seen enough failures of pulpotomy simply because the seal was not there. It is an easy procedure to do, but it comes with a lot of caveats. You ignore one, it's going to fail. Now so far I spoke about vital pulp therapies. Now let's come to the non-vital pulp therapy, which is essentially pulpectomy. So which is nothing but root canal procedure in primary teeth which have irreversibly infected or necrotic pulp due to caries or trauma. And here in the permanent teeth, we do what is called as biomechanical preparation, but here we do chemomechanical debridement. In permanent teeth, we use, the obturation is done with a non-resorbable material, but here we do obturation of the canal with a resorbable material because the root is undergoing resorption. What is the rationale? The rationale is as simple as to retain the tooth till such time it's ready to exfoliate, or many a times, as I explained before, if a child is 5 years old and with a grossly decayed, with a infected 7-5, I need to save the tooth instead of extracting. If I'm unable to give a space maintainer, then it is better to hold on to this tooth so that there is no future malocclusion. However, while doing pulpectomy, many practitioners have concern because they have concern that it is difficult to prepare the canals because the canals are fine, they're tortuous. They also have concern that you may damage the succedaneous tooth. And of course, the biggest concern is how can I do pulpectomy in a child because I have a lot of behavioral issues. While these concerns are genuine, but what I can share my experience here is most of my patient pool is I have ended up treating mostly the children who are below 5, and I usually it is okay to do it. It is not so difficult. Now the checklist, when I come to the checklist, every box is ticked yes. Patient will have spontaneous pain, he may have spontaneous pain, he may not have spontaneous pain, he may not have provoked pain, he may or may not wake up at night, because he comes with different presentations. They may be paralyzed, they may not be a paralyzed, they may be a swelling, they may not be a swelling. So every box is ticked. So in all these situations, you do pulpectomy. If you don't want to do pulpectomy, the only option is to do extraction. Now, what are the indications when there is irreversible pulpitis or necrosis? Number one, or when your operative diagnosis tells you to terminate pulpotomy and you move on to that's when you do pulpectomy, and when you have adequate root length. Now, if you see in this radiograph, I've clinically examined, there is a clinical exposure. Now, I know I have to do pulpectomy. Now, and I need to confirm also. So here I also see there is focal radiolucency. I see there is adequate root length, and therefore I know I can do pulpectomy. So these are the situations where you do pulpectomy. Where do you not do pulpectomy is when the root length is less than 2/3. There is no root, so there is no point of doing pulpectomy. You have to extract. Or if the tooth is showing advanced internal or external resorption, or when you see in this situation the caries is involving the floor of the pulp chamber. So you cannot save this tooth. This has to go for extraction. And here, if I have to extract this because the permanent first molar has not erupted, I need to give a space maintainer. Now, how is this procedure done? Again, you need to give LA. You need to do it under rubber dam. Access opening is made. Pulp is extirpated. Many times in these situations, there is no pulp also. So this is something which you need to see. But in case of multi-rooted tooth, 2 roots may not have pulp, but the 3rd root will have vital pulp. So that's why we need to give LA, because you don't know what you will encounter once you open the tooth. So you need to extirpate the pulp. You can use spoon excavator to remove the coronal pulp if there is any. And for the radicular pulp, you can use barb broaches, H files or K files. You locate the canals, and you take working length. You prepare the canals, and the key here is chemomechanical preparation. Now, when I prepare the canals, I can use manual files or I can use rotary files. Now, when it comes to manual files, you take you only enlarge the canals up to 3 times. Typically, it is said that you should not go beyond size 30. Why? Because the roots are fine. If you do aggressive canal preparation, you might end up perforating the roots. So therefore, it's better not to do overzealous. All you have to do is just debride the canals. And while debriding, you need to irrigate alternately with sodium hypochlorite and or chlorhexidine, or sodium hypochlorite and saline, while taking care that you do not use undue pressure and push your irrigant beyond the apex. Now, personally, I prefer to use H files while they're a bit stiff, but then while I'm pulling the file out, that's when it does the cutting action. So I know I have a good control on it. So it's your choice how you want to prepare it. It comes with the comfort level. Now, rotary files are in vogue in the permanent teeth for doing root canal and permanent teeth. And why should the primary teeth be left behind? So as far as back as 1993, in the US, Dr. Barr et al., they all were using 90 files as the taper and profile system in primary teeth way back in early 90s. So these are, as we all know, these are flexible files. They have shape memory, and so they can be used. Why they can't be used? So I have also used, but the only difficulty I found with ProTaper system is A, it is aggressive, B, the length of the file is quite long. So if you put the file along with the handpiece in a child's tiny mouth, it becomes really tough sometimes. So I used to restrict myself to using only the SX file of ProTaper system. That's it. Till pedo rotary files came. In the market, there are a lot of rotary files only for pedo. This file which you see is a pedo rotary file. As you can see, it is much shorter. It has the same 4% taper, and it gives a nice conical shape to the canals, and it is way easier to use this. So this is used with the endo handpiece at the speed between 150 to 300 RPM with the under continuous torque ranging between 2 to 2.5 newtons per square meter. And of course, you use the irrigants, the rest remains the same. Now, whether to use manual or rotary. Now with manual, you feel you have good tactile sensations of better control. You feel you have required sizes, and of course you feel it's economical. But the biggest disadvantage which I find is that it causes a lot of fatigue both to the child as well as the operator. So that's when the rotary files come in. It reduces, the canal preparation is just the same, but it reduces the working time, and thereby it gives better patient cooperation. And of course, you are fatigued less, so your outcome, your results will be much better. So many people, they argue saying because it's a rotary, it will cause vibration, patient will have anxiety and things like that. But personally, I have used, the children have been fine. So it's just a learning curve. As we get more familiar with it, it is as good as anything else. As far as cost, as with any other technology, initially the cost is high, and as more and more things come in the market, the cost is coming down. So I don't think it should be an issue in the future. Now, once we are prepared, we need to obturate. So an ideal material has the most important criteria. It has to resorb and at the same rate as the root, and even if it is extruded, it should be easily removed. It should be radiopaque. I should be able to see. It should adhere to the root walls, should not shrink. It should not cause harm to the periapical tissue, and most importantly, the permanent tooth bud. And of course, it needs to be antiseptic. Now, again, there are a lot of materials which are available. The most commonest is zinc oxide eugenol, which is there in every clinic, is the most commonest which is used. Some people find that there is an issue with underfilling, so they started using with pressure syringe. But the problem with zinc oxide eugenol is that if it is overfilled, firstly, it sets hard, and if it is overfilled, if it goes beyond the apex, it causes a foreign body reaction, and some reports have said that it may cause deflection. So then there are some iodoform paste like Endofloss or Crypaste. Then there are mixture of iodoform and calcium hydroxide paste, which the advantage of these is they resorb at the same rate as the primary to the root, and they do not set hard, and they do not cause any problem. And people have also used triple antibiotic paste, which is called as lesion sterilization technique, but in primary teeth it is reserved. So you can use pressure syringe. There are different things, Metapex, Diapex, or you can make a creamy mix of ZOE. You can push it in the canal with the lingual spiral, and then follow it by a thicker mix with the plugger. So here you can see working length is taken. It is obturated. It was obturated with Metapex. It extruded, but after 6 months, it's not there. Now, so towards the end, now this is the algorithm for pulp therapy. So if your patient comes with pain, you need to see if it is provoked or spontaneous, but please bear in mind, if there is spontaneous pain, please rule out if there is any food impaction, because that also causes spontaneous throbbing pain. So if there is provoked pain, it is reversible pulpitis, so you can do any of the vital therapy procedures, whereas if it is spontaneous, you need to do pulpectomy. In the clinical evaluation, if you see swelling, mobility, fluctuation, percussion, all these studies indicate that we need to do pulpectomy. Radiographically, if there is the remaining dentin thickness is less than 0.5 mm, then indirect pulp therapy, or sometimes if there is no focal radiolucency, pulp is exposed, you can do pulpotomy. But if the radiographic evaluation shows that there is a radiolucency, then you need to do pulpectomy. So to summarize, these are the simple clinical tips. If you're unsure, you want to diagnose the status of the pulp, you can just do an interim restoration and wait and watch. Or, but if there is deep caries which is approaching the pulp, you need to consider indirect pulp therapy or pulpotomy. The choice is yours. If there is caries exposure, definitely you have to do pulpectomy or extraction. And more irrespective of the management, what you choose to do, the most important thing of pulp therapy is the final restoration. If your final restoration does not provide the seal, it's going to fail. And sometimes we do pulpectomy in teeth with poor prognosis also, because the tooth is very important, as I discussed earlier on. So depending on this, sometimes we do pulpectomy and hold on to the tooth when I know that if later on I can extract and it won't have any problems. So my dear colleagues, all of us who are involved in treating children efficiently and effectively, pulp therapy offers us a good method of inculcating a positive dental attitude in the children we see. There are way too many references. These are only the few references I could fit in the slide for this presentation. There are many still which I could not fit in. If any of you are interested, you can contact me and I can give you all the references which are available. At this point, I would also like to inform that on 26th August, between 1 to 2, there is the next webinar by Associate Professor Dr. Muhammad Yusmaidil Putera Muhammad Yusuf from UITM on incriminating dental trauma in children, signs and symptoms of abuse. And this session will be moderated by Dr. Ahmed Faisal. Please do join us for another interesting webinar. Thank you so much for your patient hearing. Sorry, I've exceeded the time. I'm open for questions. You can contact me later also. Thank you.
Okay, thank you, Prof. Uma, for a very, very comprehensive talk on pulp therapy in primary teeth.
Thank you.
There are a lot of burning questions for you,
Yeah,
Prof.
I know. I was.
Okay, I will pick two for you. Now, one question is, I will take the two questions straight away. If marginal ridge is broken in primary teeth, is it safe to assume that the caries has reached the pulp? That's number one. If the marginal ridge is broken in primary teeth, is it safe to assume that the caries has reached the pulp? Okay. And number two, someone is asking, Prof, what is your experience and opinion on using sodium hypochlorite in pulpotomy in primary teeth as intracanal medicament? Is it similar as using ferric sulfate technique?
Okay. So coming to the first question, is it that the marginal ridge, if it is broken, is it safe to assume that the pulp is encroached on? Well, it depends on which is the tooth we are talking about. I'm only talking about, okay, before I answer, first and foremost, my apologies to everyone. This is a huge topic and I've tried to condense as far as possible in the short time. So there are a lot of things, actually there are way more things which need to be talked about, but I'm sorry, the time is limited. And here I'm focusing only on primary teeth, number one. So coming to the first question, is the marginal broken, then does it mean the pulp is encroached? It depends on the tooth we are talking about. Now, if you remember the anatomy of the primary teeth, the first primary molar has the most unusual anatomy as opposed to the second primary molar, whether we take maxillary or mandibular. So the first primary molars are the ones I find the most difficult to handle, because the moment the marginal ridge is broken, the pulp is very, very, very close. So there I cannot just assume that the pulp is exposed. I have to, as I said, that's why my emphasis initially was more about history taking and examination. You need to focus on the history. What are the symptoms patient is presenting? You have to look for the signs as well as the symptoms and see what the radiograph is telling you. Put all these together and then decide. Many a times a simple indirect pulp therapy will take care of it. Whereas when it comes to second primary molar, if the marginal ridge is broken, a pulp may not be involved because still there is some amount of thickness of dentine which is remaining. So it is okay for you to restore. But the first primary molars, you have to be very careful, very, very, very careful. That's the thing. Now coming to the sodium hypochlorite, the second question. Now, I was also piqued by reading, in a lot of forums, I've seen people have said that they've used sodium hypochlorite as a pulpotomy agent. Now, the thing here is, all this pulpotomy for sodium hypochlorite as a pulpotomy agent has been used only in that last step which I showed. That is, you have to achieve hemostasis first with the help of cotton pellet or moist cotton pellet. Once that is done, then only you use sodium hypochlorite, place it on the stump for 5 minutes. Now, as if you ask me my experience, so far I have not used, because in primary teeth, I'm very wary of doing a pulpotomy. I'll be very honest, because the status of the pulp is very, very difficult to discern just by looking at everything. So there are a lot of subclinical inflammation which is going on. And if the parent is not ready to get a final restoration of crown, then the child comes back with a swelling. I would rather do pulpectomy than do pulpotomy. So that's my approach. So I haven't used, but this is the literature which has shown long-term studies are still being conducted on sodium hypochlorite as a pulpotomy agent. And we still need to see what it is, how it will pan out. I hope I answered the question.
Okay, thank you, Prof. There are actually a few more questions. I would like to ask you if it's okay with you that we email you the questions.
Yes,
because,
sure.
Have short
Yes.
time. We email you the questions and we can put your answers in our social media for everyone to read.
Yeah, sure. That will definitely help. That will definitely help.
So
And
that we don't miss on any queries.
yes, sure. Definitely. I'm sorry. I was trying to be really fast and I was.
Okay. It's a huge topic. It's a huge
Yes.
topic to cover in an hour, actually.
Yes. So please feel free to email me your questions. I'll be more than happy to answer your questions, because that also keeps me going. It's an incentive for myself to challenge myself and read up a lot to answer the questions. Please feel free, no issues, anytime.
Thank you very much, Prof. So for everyone's information, we are going to email Prof the answers of email Prof the questions of some of the questions in the chat. So we will wait for Prof's reply and we'll post it in our social media so that you won't so everyone will benefit from it. Now, to close the session, I would like again to register MAPD's appreciation to Prof Umar for taking time to for the lecture with us today.
My pleasure.
Will be love to know that we had a full attendance today, 250 maximum.
Thank you. That's heartening to know.
So on behalf of MAPD as well, I would like to thank the audience for being with us today. We already, again, we have another full session, and we invite everyone to the next session next week, next 2 weeks on incrementing dental trauma in children, and we hope everyone will also support us for this series of webinar, which will go on until December. All right. Again, thank you, Prof Umar, and thank you, everyone. Thank you for a wonderful session.
Thank you for your patient hearing, everyone. My pleasure. I feel very happy that I could share my experiences with all of you, and please feel free to contact me anytime. So for any of your queries, I'm always more than happy to entertain them. Thank you.
A true teacher. Thank
you. Wow. Welcome. Thank you. Bye. Take care. Stay safe.
Thank you.
Thank you. Thank you, Prof.
Thank you, Dr. Ahmed. Thank you so much. Bye. Take care.